Okay, I think we're going to get started. Welcome, everyone who joined us today or is joining us. We're so glad that you're here. Before we jump into things, I'm going to do a bit of housekeeping. Today's Zoom presentation is what I call webinar style. So we've already gone ahead and turned your cameras off and your audio off, so we can't see you or hear you, so you can eat your lunch in peace, but you can hopefully see and hear us. You'll notice at the bottom of our box today, there is a questions and answer box that you are more than welcome to use. If questions come up as Brad is presenting, go ahead and throw those in the chat, and either Brad will stop and address those in the moment, or we have plenty of time at the end carved out for questions. My name is Caitlin Mills. I am here with Brio Living Services, also known as Porter Hills, and I am a part of our Avenues program. Porter Hills opened Avenues in 2011, and at the time, we were actually the 12th continuing care at home program in the nation and the only program here in West Michigan. We are actually still the only program here in West Michigan today. Why are we here today? Why is Brad here? Why am I here? Why are we doing this Zoom event? I will tell you why. I get quite a few calls and emails from local professionals, specifically estate planning attorneys and financial advisors, who say to me, a client called me today and they asked me about Avenues. What the heck is Avenues? I had someone tell me last week, Avenues is the greatest kept secret in West Michigan. And I said, that is not good because we're not a secret and we've been here for quite a long time. Avenues essentially is a continuing care at home program. It's an aging at home program for people who are interested in staying home and aging there. The beauty of this program is we are actually bringing the care, support, and benefits of a senior living community, but we're bringing it to our members in their home setting. It's a proactive program. It's for people who are still healthy and independent. You have to be healthy and independent to join initially. And the beauty of this program is there's a strong focus on asset protection. Once one of our members joins Avenues, all of their future care is actually covered by their Avenues membership, whether that's care in the home or facility-based care. Joining us today, one of our experts to actually talk about the continuing care at home model, to talk about what is it, how does it work, why does it work, is Brad Paulus. Brad is a partner at Continuing Care Actuaries and is the president of the board of Wesley Secure Care in Maryland. Brad, thank you for being here, and I'm going to turn it over to you.
My pleasure. A little bit about myself. I am a partner with Continuing Care Actuaries. My partner and I started our firm about 25 years ago. Prior to that, we ran the national long-term care practice for Ernst & Young. And we specialize in retirement communities and at-home programs. We're the largest actuarial provider that serves the senior living industry. Wesley Secure Care is an at-home program in Maryland, and I am the president of the board there. And what I'd like to cover this afternoon is, my slides are not, there we go. What I'd like to cover this afternoon is what are seniors demanding today? We have a changeover in demographics here, and how can an at-home program meet those demands from the seniors? So everybody knows that the baby boomers are coming. We've witnessed a lot of generation turnover just in the last 30, 40 years. So what are the implications of that demographic turnover? So I'll show you a chart, and we had the greatest generation. That was the World War II fighting generation. There's a few of those left, but not many who actually fought in World War II. There's a generation between the baby boomers and that greatest generation. They're called the silent generation. One of the reasons they're called that, don't have any US presidents that are born in the silent generation. We skipped over right from the greatest generation to the baby boomers. And you'll see, and then we have the baby boomers, and the baby boomers are just getting to this 75 plus population. Say they sort of started in 2020 where they got to 75, But you can see by 2025, we're almost there. They're half that population, 75 plus. And then another 5, 10 years, they totally take over that. So we're really seeing that flip of generations very quickly from no baby boomers to they're half the population just in a 5-year period, which we're almost there, where they're going to be half of that 75 plus population. And that's important, sort of that post-pandemic period that we're seeing a whole bunch of baby boomers come into this demographic. So what does that mean? So, and I'm going to sort of put it in terms of these life plan communities. As we look at these baby boomers coming online, they're overwhelming the space. But we don't have independent living units being built, or if they are being built, they're being built without skilled nursing. And the question is, why are they being built without skilled nursing? And so if we look at what's actually happening, you can see that sort of post-pandemic, we're having a climb in utilization for independent living within retirement communities. But again, we're not seeing them building skilled nursing. And more importantly, they're taking skilled nursing offline. 2023, retirement communities took offline 1.5% of their skilled nursing units. So it's not that they're just not building them, they're also taking them offline. So what's going on in that skilled nursing space? And what we saw is a significant drop through the pandemic of skilled nursing occupancy. And we haven't seen that climb. It's climbed a little, but it just hasn't rebounded to the level we were seeing in 2020. And if you dig into the numbers a little deeper, public payer sources haven't declined. Right? The Medicaid, Medicare are still at this similar levels as they were pre-pandemic. What we've really seen is just a plummeting of private pay. So these are people who have long-term care insurance, people who are in retirement communities. They're actively saying, we're not going to go to skilled nursing. We're going to pay out of pocket to stay in the home. Part of this is that changeover in generation. Part of it is through the pandemic, people realize, you know what, I really don't need to go to skilled nursing. I can do this in the home. And if I have assets, I'm going to pay out of pocket as long as I can to stay in the home because it's a higher quality of life. So this is what people want, and they're willing to plan for it. They're willing to put their money behind it. So what we're really seeing sort of SNF penetration rates, especially in the private pay space, not the public pay space. They're declining faster than the demographics are increasing. And the demographics are going to keep increasing over the next 20 years. And we just don't have the people who are willing to move over to skilled nursing because they're demanding that they stay in the home. And if you just look at sort of CCRCs, it's where we have some good data there. They've traditionally been, if you look at sort of the population of the whole CCRC, 18 to 22% of the residents are residing in the skilled nursing. When we look post-pandemic, that 18 to 22% dropped to 16 to 19%. That's a significant drop. We're looking at 15, 20% fewer people in the health center than we had pre-pandemic. And we don't see that rebounding. And we see when we look at the continuing care at home program, in terms of who has to be in facility care, sort of long term, we're looking at that number being 3-4%. And so you can see sort of that difference between the 16 to 19% to the 4%, or even the 18 to 22% to the 4%. That difference is really the care being brought into the home, which is what people want. So we have an inconsistent rebound from COVID. Just from a community standpoint, they're not building SNF, they're taking SNF offline. And we're really seeing a significant changeover in terms of how much home care is being delivered in a community, and also in the home, how much people want to bring that care into the home. So the challenge here is that in-home care is expensive, and we all recognize that. So you have a challenge of how to pay for it. And how to ensure that an individual, if they want that in-home care, want to stay in the home, that they don't run out of assets, that whatever their plan is in terms of that long-term care, that they can stay in the setting they want to stay in, and that they can have that highest quality of life. And that's our real goal as we talk about continuing care at home. So let's talk about what continuing care at home is. Um, and the biggest impact is the care coordination. You have a fall in your home. It's one of the things that leads to care most often. Who do you call? Especially if you're living alone. Who do you call when you have a fall? And um, most long-term care insurance policies will list in their policy, we have care coordination. You call your long-term care insurance policy, what they're going to say is, if you're sitting in the hospital after a fall, well, yeah, you need to have care for 90 days before we can provide care. It's all about what you qualify for. You call a home care agency, I have a fall. They're going to say, well, we provide X, Y, and Z services. This is what we can do for you. But nobody is coordinating sort of what you need when you need it. And that's what the at-home programs do most importantly, is they develop a relationship on the front end when you're healthy. They understand what your desires are in terms of getting care. They understand the providers in your area. So if you need help from two different providers, they can arrange that. And then they provide and pay for that care. So it's sort of important that they're sort of a one-stop shop in terms of what do you need to live your best life? And then also, how do you pay for that? And that's important. And so as we look at who signs up for these programs, we typically see sort of the averages in the mid 70s. We have people who sign up in the 60s. And truthfully, that's a better time to sign up in terms of being less expensive as you get older. It does get to be more expensive. We have a wide range of income, a range of incomes. Median liquid assets is just 450,000, a little less than $500,000. So a lot of people can afford this that can't afford a CCRC necessarily. But we're really talking about how do we protect those assets so that, because you can see, so $500,000 in liquid assets, and you'll see when I talk later on, it's not hard to burn through $500,000 as we talk about if you go to facility care. So I remember that 450,000 sort of median liquid assets. And the other thing to remember is making the decision to join the at-home program. This is a decision of what do you want your care to look like, but it doesn't need to be a final decision. So, because there's two aspects. One is that the at-home program delivers services wherever your home is. And that can be the home you've lived in for the last 30, 35 years, but it can also be a retirement community. It can be senior apartments. So wherever you define your home, the at-home program can deliver those services into that home. But if you want to move to a type A, a sort of a life care retirement community where assisted living, skilled nursing is included in that, you can, there's a bridge program available to you that you can sort of transfer that entrance fee up front as a credit to the resident entrance fee. So from my standpoint, to sort of my family history, I helped my mom keep my granddad in their, and he lived in a retirement community, but we helped him to stay in his independent living unit until he was 99. At the end, he was blind and couldn't walk very well, but he was independent. And we did it with aides, we did it with family members. And I believe that is the highest quality of life than sitting in a nursing home. And so that's the goal here. And it really is about that quality of life. So then we get to, certainly long-term care insurance can provide some of that financial, but what you're really missing is long-term care insurance. Most policies don't come in day one, and they don't have the level of care coordination. The level of care coordination really is critical here in terms of sort of bringing together the various ways people need assistance and what's the best way to bring that care into the home. So as we talk about the cost of care, One of the big things that comes back to me is, but haven't all these long-term care insurance companies gotten in trouble? How do you really know what the cost of this care is? And that's not what happened with long-term care insurance companies. And back when long-term care insurance was started, there were two mistakes made on assumptions, but they weren't the care costs. One assumption, this was late 70s when long-term care insurance sort of took off, and we had really high interest rates. Anybody who's on the call remembers the late 70s, we had really high interest rates, and they assumed investment earnings that were far in excess of what was actually achieved. And the second assumption is they assumed people would drop out, similar to annuitant buyers, that someone getting an annuity is similar to someone getting long-term care insurance. And that didn't happen. People who signed up for long-term care insurance, they kept it. They were planners. You make the decision to get long-term care insurance, you don't drop off. So I'll give you what the rate filing is for principal. So this is their national experience. They submitted a very high increase for their policies, and that's what everybody's seeing, these high increases for long-term care insurance policies. But look at the difference between sort of that second line on the right, the expected claims paid, and the line above that, the actual claims paid. They actually paid 96% of their claims paid. The problem was, if you look at the earned premiums, they had 12% more people still left over after this period, because people didn't drop out of the program. So they were expecting to pay more claims in the future because they had more people that never dropped out. So on an individual basis, they really did understand and actually projected high what the per person cost was going to be. What they didn't project well was how many people were going to keep the program. And so we actually do work for 8 different long-term care insurance companies, and we do about half the CCRCs in the country, and about 70% of the at-home programs. So you stack their experience on top of each other. The claims paid are very similar amongst these groups. We really do have a fairly good understanding of what these individuals are going to cost. So that's really not the question. It's those other assumptions that these long-term care insurance companies missed. So as we look at these as we look at individuals as they're going out, and what the claims. So this is why long-term care insurance works. It's why the at-home program works. You have a substantial number of people, maybe 30%, who don't use claims. But as we go out, 4 years of claims paid, it's a substantial number of people who are going to need facility care or total claims over 4 years. Do you know what 4 years of care is? It's over $500,000 at $350 a day. So how many people are spending that 4 years of care, which if you go back to who's signing up, sort of on average, they only have 450,000 of assets. So it's really easy to burn through $500,000 of care. And here you have the sort of the cumulative lifetime. So you can see you have about 5% of at-home members who go through 4 years of care or more. Long-term care insurance is slightly higher than that. Instead of 5%, it's around 7%. And that difference, that 2%, I like to view that difference as the quality of life difference. That's the proactive care coordination. It's focusing on what does someone need. It's being in day 1 instead of day 90, and the difference that makes in terms of someone's life. And we really do see about a total 5% difference in spend on the at-home versus the long-term care insurance. And that's really related to that care coordination and the wellness components of these at-home programs. So we're talking about being able to lower overall spend, being able to protect individuals' assets, being able to keep them in the highest quality of life as possible for as long as possible. And so that's sort of the goal of the at-home program. And so some people like line graphs, some people like bar graphs, and so we show that. And you can see sort of the last 5 bars here are percent of total claims paid that are over 4 years. And you can see that's a substantial amount. So as we talk about protecting assets, there's no getting around that long-term care is expensive. And about 20% of all long-term care claims exceeds that 4-year cap. And that's really what we're talking about in terms of protecting individuals' assets, is if they need that long-term care. It's a much greater likelihood than your house burning down or being in a catastrophic car accident. And it's going to be more expensive than that. And so in terms of protecting individuals' assets, it's that population that we're really trying to protect here. Then we talk about the quality of life. And there was a Harvard study in terms of just overall what people need to live a healthy life, live a high quality of life. And it was both, genes were an important part, but it was also the socialization. There was a lot of other factors in the wellness of an individual and the quality of life. And that's also sort of the other part of it that the at-home program brings along, is that wellness component, the socialization. They work on that with the members, and that interaction is really important in terms of the happiness and the health of the individuals, to achieve that high quality of life, which is really our goal here. And then besides that sort of wellness component, I want a lot of the difference, again, as we compare long-term care insurance with at-home program, is getting involved on the front end when someone's healthy. And what we can see is these at-home programs, they're coming into their home, they're doing assessments, they're talking to the individuals, they're meeting with them, trying to avoid some of the pitfalls that cause events that cause long-term care expenditures. And that, again, this sort of factors into how do I bring that 7% total claims cost down to 5% total claim cost in terms of our population. And we can reduce the number of falls, and that's what we're seeing, is that we really can bring down the number of falls, bring down the severity of what a fall means for an individual, because we're proactive, we're involved in these individuals' life, we're doing the wellness, which you're not getting with a long-term care insurance product. And so it's really not, can we reduce the number and impact of falls? We know that can occur, but it's how much can we reduce the impact, and how can we reduce how much can we reduce the impact after a fall? And again, that's where being proactive on the front end and getting in on day one can make a world of difference for an individual in terms of returning to that highest quality of life as possible. So I was told to try to keep this to 20, 25 minutes. So I'd love to answer any questions that anybody has.
See if we have any questions today. And it could be a question for Brad about continuing care at home programs in general, or it could also be if you have questions about our Avenues program specifically, I'd be happy to answer those today too. All right, we've got our first question. Do you know how many continuing care at home programs there are in the country?
Yeah, there's a little over 40 in the country right now. There's a couple of factors that have limited that. One is legislatures have been slow to take up who needs to regulate this. And so that's sort of the first step, is getting a legislature to just create those regulations. In every state where it's regulated under a similar statute as to retirement communities. But there's a lot of states that don't have any guidance. And I recommended to clients not to move forward if they don't have that sort of the legislature sort of on board in terms of who's going to regulate it. There's some states like Virginia and Florida that you can only do it if you're a retirement community, and boards of retirement communities aren't necessarily familiar with the risk. They understand the bricks and mortar risk, and they're not as comfortable sort of taking that risk out. So those two factors have slowed the growth a little, but we do have about 40 programs in the country, and I'm working with about another 10 clients right now in terms of developing them.
Yeah, that's a great point, Brad. And it's good to note that Avenues still falls under the not-for-profit category under Brio Living Services as a whole. And our program is overseen by the state of Michigan. So every year we have to go through our reapproval process, and we'll knock on wood, but the state has continued to approve us, which is wonderful. And part of why Avenues exists and some of the oversight for Avenues is the state.
Yeah, yes. Yeah.
We got another question that came in. What is the service area for Avenues? I'm happy to answer that. So Avenues is a program that specifically services the greater Grand Rapids area. We service about a 30-mile radius around central Grand Rapids. And when I say we service Grand Rapids, your primary residence as a member in this program has to be within that 30-mile radius. However, Avenues is pretty flexible. A lot of the members in our program travel, have homes in other states, are gone 6 months out of the year in Florida, California, and that's no problem. We can still service those people virtually or over the phone and still do a lot of the support coordination, coordinating with doctors, hospitals, if something were to happen to one of our members when they're out of state. So we do the best we can when people aren't in Michigan, but the care that our members start to receive as they're aging or situational care, periodic care would be specific to Grand Rapids. Great question. Another question that came in, it said, what are the qualifications to join programs like this? That's a great question. I can answer for Avenues, and Brad, if you want to add anything, you can. So for our Avenues program, you have to be 55 years of age or older to qualify. You have to currently be independent, meaning this is not a program where you wait until you're needing care to try and join Avenues. You have to still be independent. You have to go through a medical underwriting process. So you have to be what I'll call reasonably healthy. There are certain diagnoses that would be automatic disqualifiers. A lot of diagnoses have to do with what does your overall health picture look like? What is your lifestyle? What is your treatment looked like? Are you proactive? Do you work consistently and closely with your doctors on your certain diagnoses? So our members people who are trying to join Avenues do go through a medical underwriting process. And then finally, you have to have health insurance to join Avenues. Your health insurance, what that covers is different than what Avenues covers, and what Avenues covers is completely different than what your health insurance covers. So you need to have health insurance to cover medical specific things that might come up. Avenues is covering the cost of your care as you're aging. Great question.
Yeah, and
Anything
big
to add to that,
picture.
Brad?
Well, big picture, any form of dementia is disqualifying. If you have health issues, if you're not managing them, that's disqualifying. And then we're just looking forward and saying, do you need care in the next 4 years? I mean, is there a reasonable expectation you're not going to need care? You never know if someone's going to have a stroke, but is there a reasonable expectation that you're going to be healthy for the next 4 years? You really can't see beyond that. Those are the big pictures, and that's why people should sign up slightly younger than they probably do. A lot of people wait till they have an event or they start seeing early signs of dementia, and then they say, well, this would be a really good program to have now. Well, now it's too late. The time to sign up is when you're healthy. There is an insurance component to this that you need to be able to qualify medically.
That's so true. Avenues and continuing care at home programs, they are a plan for the future. It is a peace of mind thing for people who are starting to plan into the future, who have a picture of what they want their aging journey to look like. And most of the people I find that are pursuing Avenues want to age at home. They are already thinking about the rising costs of care, and they want a plan in place financially for the future. And also, a lot of people that are attracted to avenues like the advocacy piece. They like the peace of mind of knowing I've got a team behind me and walking with me as I age. It's not going to have to be my family scrambling to figure out my care. My family isn't going to be scrambling if I'm hospitalized or have a sudden change in health status. So, for most of the people who've joined avenues over the years, it's a huge peace of mind thing for them. It's their plan for aging. Any other questions today?
Well, I want to piggyback from that.
Sure.
I know a lot of people are worried about sort of the workforce. It can be a challenge. I mentioned I had done this with my mom serving my granddad. And, occasionally a nurse wouldn't show up. Well, we didn't have anybody to call. But the care coordinator is going to do that for you, and they're going to make sure the nurse is there. And the agencies are going to service the avenues who's hiring lots of individuals quicker, and you're going to get the highest quality of staff than someone who's calling up someone for their dad, because they're only one person. And so there's a benefit to that sort of economies of scale by going through the avenues.
Yeah, that's really interesting, Brad. I was in a meeting a few weeks ago with a gentleman and his financial advisor. And his financial advisor said to me, why shouldn't my client just wait until he needs care? It might be cheaper if he just finds his own caregivers off the streets or calls up a care company. And we had this really interesting conversation about the fact that, here in West Michigan, there are 200 plus private care companies. Sure, you can call up a care company, and then we started talking about, well, what does that cost? Right now in West Michigan, private care costs about $30 an hour. So if your client ends up needing round the clock care, you're paying about $700 a day for that
Mm-hmm.
care. And then the other big question is, who is going to still help you with all of that? Are your kids going to be managing that care? Are they going to be finding caregivers? What happens if your caregivers are calling in sick, which happens a lot, or they don't show up, or you don't like your caregiver and you fire your caregiver? Who is that person who's actually coordinating all of those pieces? What happens if you're in the hospital and you need care in 2 days when you return home? Who's doing that for you? I think
Right.
a lot of people assume I will have the capability to manage that myself and to find my own care. But what I've seen in my years of working with older adults is so many people don't. I mean, especially if you've had a change in health status and you are not feeling well, most of the time people just are not in a good frame of mind to be calling care companies, coordinating,
Right.
figuring out medical equipment, all of those things. It's complex. And if you don't have family or if you don't want to rely on your kids, which a lot of people don't want to, then you are stuck in a sticky situation that oftentimes results in a move to assisted living, which for people who want to age at home, then it's hard because your wishes are not able to be honored. So it's hard.
Mm-hmm.
Any other questions? Nothing else today? All right. Well, thanks to everyone who joined us today. Brad, thank you for speaking on continuing care at home programs in
My
general.
pleasure.
If anyone has questions after today's event, please feel free to reach out to me. If you were to have a client that asks you, what the heck is avenues? That is a big part of my job, is just the education component of what is continuing care at home? How does it work? How does it compare to other options out there? And we are just grateful that you came today to get educated on what is avenues and why are we here. So thank you everyone for joining us today, and enjoy the rest of today and the rest of this week. Thanks so much.
Bye bye.